Good evening. I think it's 5 o'clock and time to get started on our study session. I'll call us to order. And Summer, if you will call roll, please.
Commissioner Patterson?
Here.
Commissioner Norwood?
Here.
Commissioner Baker?
Here.
Commissioner Roberts?
Here.
Commissioner Stallings?
Here.
Commissioner Orr?
Here.
And Mayor Mason?
Here.
All present.
All right. Item number 2, at the Commissioner's request, discuss any item of concern on the regular session agenda. Anybody have anything they want to talk about? Okay. Item 3.1, present the Emergency Medical Service, EMS study with recommendations. And are we going to start with?
Yeah, let me go ahead and set the stage here, and then Chief, you might, I don't know if you want to say a few words now or later, but we have our consultant, Stephen Athey, here. You'll remember we started off, I'll just try to summarize just in a few moments. Over the course of several years, we have, the city has been working with our provider, Jimmy Johnson, who's here from Life EMS, the city's provider of EMS services, looking at response times, things like that, trying to work through some issues, particularly since COVID, with the challenge of everything costs a lot more. It's difficult to keep people and hire people, and the kind of people that you have on ambulances, you can't just generate with an 8-hour web course. So anyway, at some point, I will say, Chief, you've been chief now for what, 3 years or 4 years? You very early on, Joe Jackson before you had talked about a little bit, but I appreciate your leadership. You have really noted some challenges. You've communicated those quite a bit with Life EMS and with myself, and we've worked for a while, and then we thought that we came to a point where the fork in the road sort of thing, although it's not really a fork yet, it's just we need to do something else. And so we thought we needed to reach out and get somebody that knew more about it than we did, which is you, Stephen Athey from Health Visions LLC, to come in here and evaluate our system, talk with all the parties involved, the stakeholders of which there are many, and report back to us with some recommendations on what we might be able to do to improve the system that we have. The system that we have, I will just say, is a system that we have all inherited over many, many, many years. I say inherited. Jimmy Johnson, I think you've run and operated Life EMS for 40 or 45 years. I think generally you've done a fine job. The problem is the city's grown. The demand for services has grown, not only from hospitals, but from folks. And so all kinds of issues. I don't want to get into that. That's what Mr. Athey can get into. But we thought that we needed to do something more. I've also, over time, had some concerns from some commissioners up here, which are valid concerns to kind of spur us along to see what can we do. Because I say in a joking manner, although it's the truth, if you ever are on a quiz show and you're asked who's responsible for anything other than maybe flying airplanes in combat to defend the nation, it's going to be the city. It's going to be the city. It's always going to be the answer. In our city, it's been unique. We have never operated an ambulance service. We have never subsidized an ambulance service. We haven't ever felt the need. Well, I feel like we're feeling the need and the pressure now to look into some of those issues. So I appreciate, Chief, your leadership. I think with that and some prodding, it kind of got us to where we are. Would you like to say a few words before we bring up Mr. Athey to talk about the report?
Yeah, just briefly. I'm not going to say much on the topic. I'm going to let Mr. Athey speak, and then I'll help field some questions and make some comments after. But I really appreciate the support that we've gotten on the topic. I know it's a hard conversation to have. It's a very challenging issue, but in the effort to provide the best service to the citizens that we can, I'm glad that we can come together with our providers and the city and city manager support to get this study done and try to find some possible solutions to the problems.
Okay, with that, I think we're ready.
Yep. Mr. Athey?
And just again, as you get your notes ready and stuff, you remember, I think we had you here about 6 months ago or so. For various reasons, the report's taken a little bit longer, but I am pleased that it is complete now. and you've had it for at least a few days. Certainly, it's on the agenda, and we're excited to have you here, who did the report with some folks that you work with and talking to all the stakeholders. So we look forward to what you have to say.
Well, thank you. I appreciate it. I appreciate being here, Mr. Mayor, commissioners, and others. It has been about 6 months, and there has been some delays, of which they were all mine. So you guys have done a magnificent job in being responsive, and I wanted to thank especially the fire chief and Jimmy Johnson, Mr. Miller, for all of their time that they gave me in doing the research. Almost everybody had an opportunity to hear from me on the weekend or in the evenings, and so I appreciate the fact that they were very open, honest, and fulfilling with their information moving forward. My name is Steve Athey. I own and operate Healthcare Visions. Get this to work. There we go. And I partnered with a gentleman named David Baumgartner, who he worked on the ground with me here during our on-site visit. As you can see, both of us have spent lifetimes in EMS. In fact, I ran my first ambulance call in 1971, became full-time in EMS in 1976, and except for a brief stint as a successful Denny's cook, and working in the woods, that's all I've done since that time as EMS. So I know how to do it. I think I still know the key parts about it, and I was happy to be here and do this. It was an interesting project. It is not an uncommon project going on today. Folks all over the country are looking to, post-pandemic, figure out what happened, why their systems don't look the same that they did, and why they're not getting the same result. So I tell you that with a report like this, it's kind of a balancing act. And so if you've had a chance to read through it, if not, we're going to hit the high points today. But when you do read through it in detail, you'll notice that I spend some time telling you probably what you already know. You have to spend some time talking about what your system looks like today. There's no surprises there. Everybody here kind of knows what your system looks like. But I have to realize when I write these that once it hits your desk, it becomes public information, and a lot of people may read this report, and so you have to make sure that you put some context in it and talk about some background. So we followed a pretty standard method of what we choose to do when we're doing these kind of studies. We met and conferred with key people in the town, spent a lot of time with the chief, a lot of time with Mr. Gilbert, and talking about what they saw as the issues, what they were feeling, what they were hearing, what the issues were that were causing them to have some concerns. And there are some that you had capitalized already that we were hearing from you, and as we got out into doing the study, that we noticed that were talked about pretty commonly and felt like that they were pretty common themes. And that was, it was taking a long time to get ambulances during certain times. There was some delays at the hospitals. There was some concerns getting long distance trips out on time, firemen waiting on the scene to get ambulances cleared and to a scene, and then the question of paramedics turned out to be a huge issue. So we were seeing ambulance delays, we were seeing staffing issues. The city and the provider got together and worked on some compromises to be able to put ambulances on the street that I think was a smart move. And we started taking a look at some of the items that we wanted to really focus on. We asked for an awful lot of data. We got that data from city dispatch, got the data from the fire department, got some data from Life EMS. There wasn't a great deal of reporting that had been going on in the past, so there wasn't a lot of formal reports that we can draw on to see what the system has done and whether it's progressed in one way or the other. But we got enough data to be able to take a look at what we were doing. We came and did an on-site review, which gives us an opportunity to talk to people, visit, see the system in action, and draw some conclusions, and then of course the report, which is what we're doing today. I will tell you there's some things that we have as takeaways here, and historically the premise that COVID caused an awful lot of the issues that you're having today is not untrue. I will tell you, though, that the trending was going in that direction before COVID hit. We were in a situation in 2019 where we were starting to see paramedics becoming harder and harder to obtain and to keep. Situation was paramedics worked a lot of hours, they were crazy hours, and they weren't getting paid an incredibly lot of money. It was not unusual to see paramedics in 2019, 2018 working on a salary of $40,000 to $45,000 a year as an average salary. And although that seemed okay then, that was for 56 hours usually. So medics were trying to figure out a better way to use their skills. We were starting to see a lot of dock-in-the-boxes pop up. We were starting to see a lot of emergency departments use paramedics. And so we were seeing paramedics leave the field already before the pandemic and move towards a more normal lifestyle, a 40-hour week, working in a hospital, working in a clinic, working offshore in an oil rig, a lot of different ways where we were losing medics. We were losing medics on the private side to the fire departments. Fire departments tended to have better schedules, better pay, better retirement, and we saw a lot of folks leaving traditional ambulance positions and moving towards fire departments. Pandemic hit, and of course it worsened everything. All the rules were gone when that happened. Cities that had the strongest regulatory components to their systems, that were measuring what their system was doing to the weekly degree, all of a sudden all that went out the window, and folks were just glad to have ambulances on the street. And when you had ambulances on the street, that's all you worried about. Same thing with nurses in the emergency department, surgery folks in the surgery staff. A lot of things got kind of pushed to the side as we just figured out how we were going to survive. And as we started to come out of that COVID, things didn't bounce back. In 2021, there was 2,500 reports in the national media about EMS and how 250 services had quit, stopped operating, and had to be replaced in some other way. That there was staffing shortages were mentioned in 42% of those articles, and 38% of them mentioned funding as a major issue. Those are the two issues that you're seeing here today, is staffing and funding. So you're not alone. You are in a situation where others have gone through this, others are going through it today. Many systems are looking at where by 2022, 2023, they started trying to get back to normal, started to hold their providers responsible for response times, make sure staffing was right, and what they noticed is their systems were different. They will never be the same again. In some systems, if it took 20 ambulances to run a system, now it was being done with 15. And that has some gaps, that has some issues. So everybody came out of this different. Everybody came out of this with issues that had to be addressed, and most of them addressed it through a system redesign. You have never designed your system. Your system has evolved, and it's evolved nicely. It's when something happened, some action happened, some reaction happened to that, and along the lines you ended up with the system that you have today. But nobody ever sat down and said, we need to design the system that we have and make sure that it exactly faces the challenges that we have. And you now have an opportunity to do that. I will tell you, one of the biggest takeaways is your system is underperforming, primarily in response times and in staffing. And those are the two major areas, of course. Of all the things that you want to have solid, the number of ambulances on the street and the personnel in the ambulances are, of course, what you want. And you're in a situation where your expectations weren't being met. I like to say there's two types of systems. There's a system that yesterday was your best day, and there's systems where tomorrow is your best day. I've got a couple systems that I'm working with where through just luck mostly, tomorrow is going to be a better day for them than it is today. And it sounds very simplified, but Grayson County, Texas, couldn't afford the ambulance services they needed to cover the geography. This is some time back. But guess what's happened in Grayson County? Everybody's moving from McKinney, Dallas, Fort Worth, up into Grayson County, and all of a sudden they become a destination county, and their system's getting better and better because they're getting money to fund it. Same with Rockwell County, Texas. People are moving there. It's the smallest geography county in Texas. People with means are moving there, and that system will be better tomorrow than it is today. I'm not sure I could say that here. I don't know that you've got that same positive force going on. You've got issues with funding. We're going to talk about funding in a minute, and you've got issues with staffing, and those have to be reversed. And I think there's some good design elements that we can do to make that happen. I also want to say there's no indication of large-scale system failure looming. I think the system is operating. It's operating fine. And if it stayed the way it was today, you guys would get by. You've done a great job of working with your providers. You've done a great job working collaboratively to make things work. And for the most part, things work. But I will tell you, it doesn't take much for the system to kind of see its weaknesses. And that happens when you've got out-of-town transfers that are backing up. That happens when you've got multiple county calls. That happens when you can't staff an ambulance that you want to staff. And so the potential is there for the system to have some issues, but there's nothing catastrophic going on. It's really nice to work in a system that's not in complete crisis. And I think that you're in a situation where you're going to have time to make some positive steps to make your system better. The system is under-resourced, there's no doubt about it. It needs more people, needs more ambulances on the street, and there's not available funding to do that. We're going to talk a minute about the funding, because I think the funding is really important so that everybody understand why funding is an issue. Because it hadn't been before. Funding always seemed to be fine 5 years ago, 3 years ago, 4 years ago. Today it's not, and I'm going to show you why, because to me that is a real important message for everybody in the decision-making process to understand why funding is an issue with your EMS today. Right now, you fund your EMS system through a couple of ways. You fund your fire department, you fund your police department, you fund your dispatch center through city tax dollars, and that's how you choose to fund that. You have never chosen to fund your EMS that way because it hadn't needed it, and nobody wants to spend money they don't feel like they need to. Your EMS system has been funded through itself. It's funded through the only 3 ways that EMS can be funded. And one is through user fees. You bill up somebody, you get paid some money back, you use that money for your company. The other is for tax base or other kind of subsidy. The third is a combination. This system has been funded entirely through user fees. And user fees consist of Medicare, Medicaid, commercial, and private pay. And when you look at that list, you think, okay, what does that mean to me? Well, what it means to you is depending upon where the break is as to how many patients you have under commercial payments, which is insurance, how many patients you have on Medicare, Medicaid, and don't be fooled with private pay. Private pay means no pay. That means a patient has no insurance, no Medicaid, they're not on any type of sustenance at all, and they have no ability to pay you. I would guess that if you're anything like the national average, for every $100 billed to a private pay patient, you may get $8 back. And so it's really one of those buckets that you want to have the fewest of. You want people to fit one of the others, but in reality, they don't get that way. Medicare is getting harder and harder to collect. It's not diminishing, but it's not increasing either. We just got a notice across our EMS hotlines basically saying that the president has signed HR 168, which keeps a 2% increase in urban Medicare, a 3% increase in rural, and a 22.6% increase in super rural. That's not new money. That's just money that they are keeping going for another year. The last time they gave us any money is 2004. So except for some cost of living increases along the way, Medicare has become harder and harder to collect with different rules, different regulations, and the money isn't there to see increases. Commercial payment used to be where we made our money. And when the insurance, back in the days of Blue Cross Blue Shield and 80/20, where you sent them a bill for $1,000, they paid you $800. Those are gone. When they looked around, when the commercial payers looked around and they saw that we were cost shifting our revenue onto them, they said to themselves, if Medicare is going to accept $400 for a payment, why are we paying $800? And they started capping their payments, and commercial payments all of a sudden are now getting less and less and less. So the revenue is hard to collect, and it's getting harder and harder, and it becomes important because of this. There is no doubt that you could look at this and understand that this is a truth. It cost more money to run a transport today than it did yesterday, and on and on and on. The cost per transport line is going up, and it continues to go up. Those medics that were making $35,000 and $40,000 a year in 2019 are now making $80,000 or $100,000. There's actually an ambulance organization out there that is offering a $35,000 hiring bonus to bring a paramedic in. And they're not making you wait 5 or 6 years to get it. It starts on your first paycheck. $600 extra for as long as that $35,000 lasts. That's the kind of things that people are having to do and the money they're having to spend to get paramedics in the door. So when you start paying those kind of salaries and those kind of increases, I know that Life EMS has had increases. I would guess that Miller EMS has had increases as well, because what got you a paramedic in 2020, 2019 won't get you a paramedic today. So your cost per transport continues to rise. That's a given. Your cash per transport continues to go the other direction. Now, this isn't a realistic chart. This is just a chart for illustration. But the cash per transport year over year is going down. We used to worry a lot about collection percentages and talk about, you know, if my collection percentage is X, then that's good, and if it's Y, then that's bad. Really, smart providers nowadays aren't really paying attention to their collection percentages. They know that it has to be maximized, but what they look at every day is what's my cash per transport. And if they plot it on a line, I tell this to my clients all the time, figure this one out. Go look at your bills for the runs from January through March, and on June, take a look at it and see how much money you collected in. You'll know exactly what your cash per transport is, and it's going down, I can promise you. You're probably somewhere on the other side of that dotted line. There's still room to where your cash per transport is more than your cost per transport. When those lines touch, you can't make it up in volume, and your system is dead. And you're headed in that direction. Don't know where that's going to happen. I've had a client before that when I gave this speech to them went and did this and then ran the numbers and knew that 4 years and 7 months later, those lines would touch if they didn't do something different. And you know, the idea, of course, is to keep some separation there, so there's more money coming in than it costs you to go out. But that's what's happening in EMS systems around the country. It's not just happening here, it's happening everywhere. And I believe that, you know, here, somewhere along the line, that cash per transport and that cost per transport, those lines are going to touch, and then the only way to continue operation is to provide some additional revenue. And I think we're coming close to that situation here, which is why later in the recommendations, I recommend that if you want more resources, we're going to have to figure out a way to pay for it. In this operation, these are the rates that are being charged. Those look like healthy rates. I think they are healthy rates. We talk about looking at a potential rate increase later in the report. I don't know what it's going to bring you really. I look at this and I see that these are probably pretty standard in the state. You may find some higher, you may find some lower. But just know that although those rates look very healthy, I will tell you that the numbers that I ran, I think Jimmy Johnson's operation is, you know, probably collecting about 30 cents on the dollar. And so even though they might have an average patient bill, I think I said somewhere of $1,080 for the average patient bill, that's not the dollars they're bringing in. And at 30%, he's doing exactly what everybody else in the country is doing. If he was doing 35%, then he's probably stiffing somebody. If he was doing 27%, then he's leaving money on the table. And I think he's right in the sweet spot of where he needs to be. So there may be an opportunity to raise some rates. Also in the state, there's a couple of things going on that could improve some payment methodologies for both Medicaid and some minimum payments for the commercial payers. But for right now, you know, revenue is one of those items that needs to be closely watched in the system, especially if we're going to ask you to add resources. So we get to the recommendations. The report, some of these kind of overlap each other because I broke the report down into certain segments. And I just want you to know that the recommendations are, I couldn't give you recommendations that says you should absolutely do this, you should absolutely do this, because there's so many unanswered questions that need to be made by you. I could suggest them, I could think what I know is the right answer, but they're really local EMS, local governmental questions that need to be answered by somebody. And that's why we recommend that a steering committee should be chosen by the city, and that the city manage that process, considering that they're going to be the contract holder. And we strongly recommend that they are the chair. And you'll see several times in our recommendation that we recommend some strong voice and some membership from the medical community. Systems today that want to be the best have to do two things. They have to be patient-centric, meaning they're making all their decisions in the patient's behalf, and they have to be medically driven. And although you've got a very strong medical director around here, who is the medical director both for the fire department and Life EMS, and many of the volunteer fire departments out in the county, he's not been involved in system design questions and answers. And I did talk to him just the other day to give him a heads up that, you know, I put him in this report and that he should know that. I'm not suggesting that he has to follow what I think, but I do think that a system is better when major decisions are made with medical director input, and thus that recommendation. Also, although this is a presentation, this is a workshop. I don't mind if somebody has a question that they don't want to wait to the end and want to ask. I'd be happy to stop and answer it. You're not going to throw me off. I like to say I've got 3 presentations, the one I prepare, the one I give, and the one I wished I would have given. So I'm going to try to make them all 3 as close as possible, but please, if you have something you want to talk about right now, feel free to break in. I think you should keep your ordinance in place and continue restricting permitted providers to 1. I came before you in 2008 or 2007 and recommended that allowing more than 1 provider in to do 911 or the calls here, all that does is split the revenue. It doesn't give you more ambulances. It doesn't provide better service. And I stand by that today. Our recommendation would be that you know, while you're working through this process of a redesign, that you not tip over the apple cart and let other providers in until you're sure what you want to do going forward. We think the city of Enid, during this, when they put together this multidisciplinary team and they start meeting and they start discussing, unfortunately this isn't linear. I can't say here's step 1, here's step 2, here's step 3. There's kind of like 1 through 5 that you got to get working on right away, and then it'll start working in dual or triple tracks on where you need to be. And one of the things that you have to do in this committee, I think, is make the informed decisions about your system boundaries and market segments. There's an awful lot of decisions that have to be made by your group about what do you want to be responsible for as the contract holder to your provider and therefore the regulator of this system. Do you want to be responsible for the 911 only? Most cities do that. A lot of cities do that. When they put a bid out, when they do a contract, it's for 911 only. Do you want to forbid or allow your provider to operate in the county? You do. You operate in the county, and so there's some suggestion that you could limit or segment out the population to where whoever your provider is must have a system that runs only in the city, and whatever else they do, they just do. I will tell you, the state requires that Life EMS, through the EMS plan, has to operate on the county and run those calls in the county. But those are decisions that you have to make as far as those market segments. Long distance transports. There are actually cities under their contracting that will regulate the long distance transport market. I'm not sure I would recommend that. Getting into that market puts you in the front porch of both of the hospitals, and they all have corporate offices, and it's probably not necessary, but I will tell you that's an option. And as we talk about in these committee meetings, what kind of options do you want to look at? Those are options you can do. Each of those choices have a cost to it. If you limit it just to the city and don't allow your provider to run any of the other calls, there's a cost to that. And your provider has been able to make it and thrive and survive in this location because they've been able to run your 911 calls and run the other calls as well. It's never been a problem before, but it's only since we've not been able to put enough ambulances on the streets to do all of that has this become an issue with staffing and response times. So those are decisions that you have to work on. That's also a system design issues that allows you contact your provider to transport patients in the county. We've talked about that. I think that's something that you're going to have to do only because it's part of the state EMS plan. City of Enid should immediately begin working toward a negotiated agreement for services with EMS. Your ordinance isn't bad. Your ordinance is actually pretty good. It's well written. It covers the basics, but it kind of covers them at the 30,000 foot view. And anytime you want to change what you expect or what you're going to require, demand of your provider, you have to go back to your ordinance and change it. And I think that the better way to do that is to have a negotiated agreement, to where you actually have a contract with whomever your provider is. There are some elements of your ordinance that don't go into enough detail that a contract will. And I think that you can keep your ordinance, keep it at the 30,000-foot view, so it talks about the law and the permitting process, insurance requirements, those sort of things that are important to your protection. But I think it's important that you guys start working on a negotiated agreement with your provider to spell out the details. And I'll just give you one quick example, response times. There's not a definition of what the response time is. Is it when it hits his CAD? When it hits the 911 CAD? When the clock starts? So that's a simple little thing, but if you're going to eventually hold your contractor to real strict response time requirements, you have to know those definitions and know when those things happen. And there's many of them that we found that need a contract explanation so that your provider knows exactly what's expected of him or her, and that you know exactly what their responsibilities and your responsibilities are in that contract. There was a lot of discussion about the fact that there's noncompliance going on today in staffing and response times, and maybe has been for some time, and there's really never been any repercussions. And I'm not a big penalty and fine guy, but I do think that it's important that your contractor knows what the rules are, agrees that they can do the rules, the performance to meet those rules, and if they can't, that there's some repercussion for that, either breach letter, a fine structure of some sort. And again, those are all decisions that have to be made later down the road, but I do think that there's something that should be discussed, that it's a two-way street. We're going to put you under contract, especially if you start talking about subsidy. We're going to put you under contract. We have higher expectations. We might subsidize you to meet those expectations, and if you don't, there's going to be some things that happen. And those, although in your ordinance it talks about some atomic bomb kind of discussions, there should be some intermediate steps as far as fines and notices. The other issue that has come up a couple of times that we feel strongly about is some of the discussions about minimum level of staffing required to deploy ambulances. Response times could fit into this category. All of those things that we think we've known forever, that faster is better and paramedics are the best, and those are the only two things we should worry about in the system. Well, I'll tell you, the science doesn't always back that up. It's another reason I'm suggesting that you move towards having some medical direction on your committees to talk about these things. Is there room for 2 paramedic trucks and an AEMT truck? Is there room for a 10-minute clock instead of an 8-minute clock? You will find no studies that say one's better than the other. And think about it, every minute is money, right? If you make it 7 minutes, it's going to cost you. If you make it 11 minutes, it might cost you less. So, and those are decisions we shouldn't be making. Those are decisions that your medical director should be making, and making them in the patient's best interest. And you will find, as you get into a lot of these decisions, as to what's the right amount of staffing, what's the right structure, what's the right response time for a certain level of calls, what's the right fire response, whether fire departments should respond on every 911 call or only select 911 calls. Those are all decisions that I think are open for discussion, and discussion that you all should have in these meetings. You guys were contemplating, and I understand that maybe you're moving forward with it, having a study done on the communication centers. There's a lot of discussion about the communication centers. I didn't feel bad about the communication centers. I think there was some times that 911 centers made some errors. There were some times that Life EMS dispatch centers made some errors, and I didn't see that that was widespread. I didn't see that there was a danger going on there. We thought it was clumsy at times. There's some technology fixes that could really help what's going on there. The phone call handoff from 911 centers to the other, as opposed to a CAD to CAD link. There's better ways of doing it. And I did read Mission Critical's our proposal to you. I don't know whether you could use them or whether you could use somebody else, but I do suggest that if you're still contemplating some enhancement of your 911 centers, that you move forward with that part of your system redesign and do that. I will caution you, however, though, that there was some early discussion that potentially moving Life EMS into the 911 center or having the 911 center dispatch everything would be an improvement and maybe save Life EMS some money, and therefore that could be a subsidy in kind. I'll want you to look at that very closely because that's not always the case. I will tell you that probably with both Miller and Life, if you asked to move their 911 part of it into a 911 center, they would still have their dispatch centers. They have other businesses, they have non-911 calls, they have 7-digit numbers, calls that come into their systems, and so they're not going to save the money that you might think they are. The other thing I'm concerned about is Life EMS provides emergency medical dispatch, which is a great thing in this system, to be able to have somebody call 911, get transferred to Life, and get questioned through medically directed, clinically proven protocols that can talk you through what to do on the scene. Whatever you do, don't lose that. That's a real asset to your system, and I would strongly recommend that you pay attention to that with any move you make going forward with dispatch centers so that there's not a loss of emergency medical dispatch. I think that's an important component in your system. We talked about the rate increase. I don't know how much money you would see with a rate increase. The ordinance say that that's Jimmy's to do, and he just has to report to you. But I might suggest as part of this collaborative effort going forward that that be on the agenda somewhere along the line to take a look at what might be included in a rate increase and whether it makes sense to do it. Just know it, as a governmental body, you'll face some heat for that, of course. And it's not a great way to raise money. I will tell you that nowadays with the cap on Medicare, the cap on Medicaid, the private insurance, the private payer that doesn't pay, and the commercials that's now mostly capped, across the country, if you raise rates $100, we're seeing $12 come back. So there is some money there, but it's not much. It's not like if you raise $100, you're going to see 70. We believe the City of Enid should begin the process while negotiating the agreement of subsidy considerations, fully evaluating the option. And on the next page, we talk about the fact that in this document, you'll notice 3 or 4 different methods that we talk about as far as subsidy evaluation. We think to add a 24-hour unit, 7 days a week, 365 days a year, it costs about $900,000. I'm not saying that's yours to pay. I'm saying that's probably what it cost here to add a 24-hour truck to this system. Now, you get in your first meeting, Jimmy Johnson may say I'm an idiot, but I think that's what it will cost, is somewhere in that neighborhood. It doesn't necessarily mean that's money that you've got to find out of pocket to start paying some ambulance provider to do, but that's what it's going to cost. So if you do a 12-hour truck, it's maybe half that. If you realize that by putting a third truck on the system, that Jimmy might now be able to pick up some of those long-distance transport that we mentioned in the report, that he lost revenue because he's chosen not to run those so that he could keep ambulances on the street. There's lots of things that you should think about as you're looking at, the 522 districts, which I don't think is practical for a city. The assessment, which I do think is practical. It's what Western Payne County does. I've spoken to the developer, and not the inventor, but certainly the person who implemented their assessment program, and he is willing to come to any meeting you'd like and to help you think through that and take a look at what that revenue might bring you. In the report is a chart that talks about at a 70% participation, there's about $900,000 that could come your way. You get to pick the price, you get to pick what it covers, those sort of things. I will also tell you that in the state of Oklahoma, you can mandate an assessment. Now, that's just another word for a tax.
You can what?
You can mandate an assessment. The one in Western Payne County is voluntary. People were opted in through their water bill, and they could opt out, but somewhere north of 70% of them have chosen to stay in. It's a small amount. They see the benefit in it. They know that it's provided other ambulances to their system. I think they're staffing 4.5 ambulances today in a system not unlike yours. And so it's a necessary resource. It's a necessary financial resource to add the revenue to this system to get the kind of coverage that you want. I don't know exactly what a third ambulance on the clock, 24 hours a day, 7 days a week. We could make some conjectures of what it's going to do response time-wise. Your response time, you're way out of compliance in your response times, and I don't want to be alarming about that because, when you look at it, you're transporting, 14 patients a day in the 911 system somewhere along there. So to be at 90% at those calls, you got to make it to 12 of them on time. Right now, you're probably making them to 7. And so there's 3 or 4 or 5 trips a day that aren't being made in the 8 minutes and 59 seconds. Again, it's sometimes hard to break out what's in the city and what's in the county, so those are kind of rough estimates. But I could promise you that more resources means better performance. It's not wasted. And so, although I may not be able to tell you that I can promise you'll be at 90%, 8 minutes and 59 seconds if you add that third ambulance, I can promise you'll be better. And being better, having that third ambulance there gives that freedom to go out in the county without putting the chief and his folks in a first response and a long response while they're waiting for an ambulance to arrive. Any added resource in the system makes things better. And, the system was taught, I haven't mentioned the word once yet, but, we started out talking about sustainability. And the reality is performance equals sustainability. If you perform operationally and financially, you sustain yourself. And it's only when one of those two things fall out of whack does the sustainability come into question. And I think you've got an opportunity here. I think you've got a positive opportunity to take a look at this system from the ground up and maybe for the first time ever, design it and make it look like exactly what you want. You've got the components. You've got folks willing to work on it. You've got a collaborative effort amongst the folks in this room, and I think that you've got yourself a challenge in front of you, but I also think that you've got the pieces in place to make this thing work. I'll be happy to answer any questions.
Could you explain what a 522 district is?
Oh,
And-
maybe.
And I believe Garber is one of the, has
Garber
that.
is one,
Okay.
and yeah, in my report, by the way, on the last attachment is a full explanation of what the 522 districts are. But it requires a vote, and you set boundaries based on any number of ways, but a lot of folks do it by school districts, and it goes to the citizenry, and it becomes a millage, where, if it's voted in, then a millage is assigned specifically for EMS. And there's a lot of 522 districts in the state. Some of them have been here a very long time. Some of them have some size to them. It makes it tough when it's a city of this size because it means forming another board. It means having an election in and out of the city boundaries. So it's an option. I think it would take a ton of work. And there's maybe better options than that one. Matt, how'd I do? Close?
I think with the 522 districting also, there's limitations. So there's a maximum limit that you can charge by the millage. And not that our need would exceed what they're currently allowing. But for example, 10, 15, 20 years down the road, if our needs drastically changed, you're limited on what you can draw as revenue from a 522. So doing it separately through an assessment, through utility bills or whatever options we may look at, there's other things that allow more flexibility as you move along through time.
Questions?
Well, I think my question is, where do we go from here? I know you're going to develop a committee, we're going to throw all that on them
Yeah.
and say, tell us what to do?
Well, to answer your question, Commissioner, I don't think it's sustainable the way that we're going right now.
I don't
I
disagree
think
with
those
that.
lines are going to cross,
I think he's been.
yeah, sooner than later.
Articulated that.
I've already started putting a list together of who I think would be the stakeholders in this. I'm open to more suggestions on that. I also know that if you get too many people on a committee, it just becomes a
Yes.
choir. It doesn't actually ever get anything done. So we are going to form that. Whenever I do that, I intend to set a time limit on that.
That's what I was going to say.
That's the other open-ended piece, that committees never finish anything. And I intend to have, and I don't know, we can talk about it, but there's going to be a start, an end, and a plan when we get done. It is my goal. I personally have several questions. I just wanted to let my commissioners talk all they wanted. But so, Rob, to answer your question, I don't know. We've got to figure this out. It's not really an option. I think there's going to have to be subsidy there. I don't see any way that we can continue this direction. So don't know how that is. As I read this and I studied it from cover to cover, I actually ended up with more questions than I did answers by the time I got to the end of it.
I don't know whether that's good or not, but okay.
Well, and I'm not going to go over all of them tonight, because the more I thought about that also, a lot of this probably is better in a committee anyway than trying to, thrash it out tonight. But there were several things I wanted to know.
Yes, sir.
I was curious how many long trip transports that you currently do, that Life does right now per month. When we go pick up at the hospital and we run them to Oklahoma City, is that 5 a month, 10 a month, 20 a month?
Well, I ran a couple of different months. Actually, I ran January 2024 to June 2024. And there was January to June, it was 6 months. Okay, so for the year, it would have been 106. Now, understand that there's more than that. Miller EMS is running their share of long-distance transports. Jimmy Johnson, in fact, in the report, you saw a chart where the difference in 2023 and 2024 of calls that Mr. Johnson has chosen not to run so that his units would be in town. But so we know that he in fact did run the equivalent of 106 annual calls.
106? Because I just did some rough math on that. I looked at number of hours in a month. I looked at a turnaround trip of about 5 hours by the time 2 hours down, an hour to get a meal or fuel or whatever, and 2 hours back. They're going to burn up the best part of 5 hours before they get back on call. If you divide that up, anything past 7.2 trips drops us below the 90%. I mean, it drops us way down there. So that answers one question for me. I also wanted to know, so Life is also covering 2/3 of Garfield County, is what I'm understanding. Miller takes 1/3, the eastern third, and Jimmy, you take all of Enid and 2/3 of the county. So I'll go back to the question on the 522, because when I read all the explanation on the back page, like you were talking about, it was talking about how you can do all of a county, part of a county, multiple pieces of counties. I mean, it went through a whole scenario there. But has anybody tried to run the revenue on 2/3 of the county, including Enid, what that would generate, the 3 mills?
It wouldn't be hard to do. I will tell you that the county calls is probably 2 a day, 2.5 a day. It's not many in his book of business.
Okay.
Jimmy, you pipe up if you think I'm wrong there. 2.5 or 3 a day in the county. And again, we have to remember that in the area you consider the city of Enid is a 3-mile buffer that includes the county. So some of those calls, you might be counted
I
in the city,
understand
not a
that,
county.
yeah.
But
I
it's-
do understand
yeah.
that we run out there about 3 miles. But we don't, unless we have a wildfire way out there, we don't dispatch farther than about 3 miles. Am I
We do
right?
have automatic aid 3 miles all the way around the city, and then mutual past that.
Okay.
They request.
Only if they're
Help
requested,
after
and you
3
have to
miles, yes.
send a truck up there. So I guess what I'm getting at, if we were to try to pass that, a 522 district, and let's say that the county turned that down, would we still have to send an ambulance to that area, knowing that he wasn't being paid for that?
Right now, the state EMS plan includes Life EMS running those calls. So they're obligated by state to run those calls.
That's what I thought. Jimmy?
If those calls are in our designated service area, we're required to give the
Jimmy, come up to the mic so everybody in
Yeah,
TV
so-
land can, or YouTube land can hear you, and we can record this for posterity.
Okay. We're required to give the state of Oklahoma our service area that we're responsible for. We can shrink that by simply telling them we can no longer cover that area. And then we're not responsible for that area.
I guess where I struggle with this some is, I know we're going to have to subsidize this. I just don't see any other way about it. It's just how we are going to do that. If we throw that on our water bill, which we can do, and I looked at all of your diagrams on the back on $3.63 is what Oklahoma City does, Stillwater $5, and there's some different programs on the water bill. I just hate to see the city of Enid have to fund this thing, and then there be 2/3 of a county chooses not to do that, but yet they still get the service. Yes, sir?
There's a third method, and it is, not everybody has water. They have wells. 522 districts are limited to 3 mills. But if you were to do an electric assessment,
Well,
everybody has.
I've been trying to deal with OG&E.
They're tough. Some of the,
Who is a great partner of the city of Enid.
Yes.
pardon me?
Go ahead, Jimmy.
Go ahead.
No, we were just talking about OG&E, a great partner. But let's be frank, it's probably, that probably is not going to happen in a timely manner. So when I hear the mayor talking about time constraints, and I'm thinking about who's going to be on this committee, that's not, I don't want to rule it out long-term, but I think, I'm going to jump in here because I'm the city manager, and guess where all the problems fall in the city, typically with the fire chief and all. We're going to be, certainly we're going to set up a committee. We're going to follow your guidance. I can already think of a dozen people. I think this committee will probably be 12 to 15 people, depends on how much representation you want from the commission. It will be a unique committee because I think there'll be competing interests in there. We'll all be united on what we want. We all want that ambulance to show up as fast as it can. But guess whose job it is to do that? Currently, it's Life EMS. Now, they're doing it the best they can with the funding, which you've talked about, which is will be very important to me because when we talk about, and it's not lost to me, you talk about the recommendations, focus on the city first. You know, I kind of think of, I guess I could use some Trump-like language and say Enid first, but it doesn't mean we don't care about the county. But when we're paying water bill subsidies, that's the city. And so that's part of the hard part I know we're trying to figure out. That will be difficult to figure out, but it will provide some money. But that's my concern is we all want the same thing, but you said it, Mr. Athey, nobody wants to pay. I mean, insurance companies, government doesn't want to pay much. Private pay is practically nothing, and everybody wants it, from the hospitals to me if I'm having a heart attack, to people that don't live in the city limits, they live in the 3 miles, and some people are frequent flyers too. There's all kinds of issues. So, but go ahead, Jimmy. This is going to be a lot of committee work, but we got a lot of time and a lot of questions. This is very important.
Yeah.
I think of it.
Right.
The other thing, when we do an interfacility transport, much of the time, we call in a crew to do that if we have the time to do it. And we've got the personnel available to come in.
Okay.
Here's the other challenge I was going to throw out, that I've gotten educated, not as educated as you, Chief, or you, Jimmy, or you, Mr. Athey, or you, Mr. Miller, but quite a bit. Our ordinance requires 2 ambulances all the time, and we know that doesn't happen all the time. I don't know what the exact percentages are, and there's reasons. So it's great to call folks in, but what my expectation would be, based on what the commission tells me, is we want 2 ambulances all the time. We don't want one of those ambulances hauling somebody for a hospital or going out in the county if it leaves us less than 2. And we have to figure out, that's probably not reasonable all the time. I don't know. And 2 ambulances we don't think is enough. So that's kind of the challenge that we're going to have too with the committee. And Jimmy, you're going to be a part of that. Matt, you're going to be a part of that. Chiefs, and a whole lot of other folks. So it will be a lively committee because we all have the same goal, but we have different ideas how to get there, and it's going to be interesting. So I think time constraints is good, because we could spend years on this and still not come up with a perfect solution.
Done, yeah.
We're just looking to make it better than it is, and I'm not saying it's not good right now. It's good when an ambulance shows up on time and you need them. It's not when they don't. So. Well, go ahead, Jimmy. I'm going to stop
I
talking.
don't know that I had anything. Those are the 2 things I had to address.
Okay, and Stephen, I've got another question for you. And I know this will make the chief cringe, but if we were to move this whole thing to the Enid Fire Department.
Yes, sir.
As an EMS service, right, would we still have to cover 2/3 of the county?
No, it's not in your EMS plan, so you don't have to.
Okay.
Now, I did mention that that's a model that you could look at. It will not be less expensive, I can promise you that. It may be very good, but it will not be less expensive.
Yeah, I saw that in your notes. Yeah, okay.
Mr. Athey, quick question. Looking at, what we're trying to wrap our hands around also, what do you think is a realistic time frame if you want to try to do this as quickly as possible? I mean, I know sometimes you can rush into a solution and shoot yourself in the foot. What do you think is an appropriate time frame to expedite this?
It all depends on what funding method you're looking to do. If the city said, look, we'll fund this for a while until we decide the better way to do it, you could start making improvements in 30, 60, 90 days, quite frankly.
Okay.
But if you're not going to fund it first, that you got to have either the assessment up and running, 522, which is very lengthy. It could be 6 months to a year.
Okay.
That doesn't mean you should not be working towards, because contract, you could start doing that immediately. Changing the ordinances, you could start doing that immediately. Medical director input, you could start doing that immediately. So, but the matter of getting additional resources on the street will take some time based on funding.
Over around Garber, did they pass the 522 district the first time?
Matt?
Overwhelming majority.
I'm sorry,
86% yes vote.
80% approval.
That's impressive.
And then we also expanded our area and it passed.
Do you mind coming up to the mic? So we appreciate your input.
So our first one passed. Garber EMS was in existence, and due to funding issues, staffing issues, they had to close. So the eastern part of the county went without one for a couple years. They were very happy to pass it. Then some citizens in the northern part of the county approached us, which would be Pond Creek Hunter School District. They approached the 522 board and wanted to join. So in order to add the Pond Creek Hunter School District to the Garfield County Ambulance District, the existing members have to vote yes, as well as the area that wants to come into it. And so both areas voted overwhelming yes to add another area into the Garfield County Ambulance District.
So I read in here that you've got 200 personnel.
Correct.
So how do you, I guess if we subsidize this and we throw $900,000 at it, how do I know that we're still not going to have a staffing problem? I mean, what are you doing that you've got 200 employees? And is that still called, do you have a staffing problem even at 200 employees, or?
So our units are staffed. I will say that paramedics are difficult to get. We're having to throw out hiring bonuses, as he said. We've upped our wages several times over the past years and are looking at doing it again. So what we have a benefit of is we're pulling from all over the state. We have some other, we have different opportunities within the company that interest some people. We have an education department. We have more administration positions. And we have, we have transfer trucks. We have 911 bases. We have combination bases. So we kind of cover a broad spectrum of 911 and transfer IFT here in Oklahoma.
Are your collection rates better than 34%, or do you know?
I don't work on our collection department. I can do what?
32.
32.
32. Okay.
Matt, just, do you know how much the 522 for Garber and Hunter generates a year, roughly? Is it 900,000? Is it 500,000? Okay. Who oversees that? The county excise board or something, or?
So, through our 522, when one passes, the county commissioners appoint a board that oversees that, and the county collects the money and deposits it into the 522 account. There are restrictions. It has to be used for EMS. They have to pay so much. And some places run their own 522 service, like as a county ambulance, and some contract private EMS, such as Garber or the Garfield County.
And Matt, did you say how much the 522 collects over there or generates?
Approximately 260,000 a year.
Okay. Do they do anything where they put anything on water bills, electric bills?
We also have a subscription service, which would be probably similar to something like Jimmy's right here in town.
Right. And throughout the state, we have we have opt-out, opt-in, and then mandatory assessment, depending on what town we're talking about.
Mandatory assessment. What are you talking about there?
So some towns do not let their citizens opt out of the charge on the water bill. That's what you get, and there's not an option. If you're getting water from us, you're going to pay for the assessment for the ambulance.
Okay. Okay.
Mr. Athey, I think you told us we could do that. Other cities like Stillwater don't do that, but they have about a 70% compliance rate, I guess, or?
Yeah, they do, that's right. And
Opt-in,
they were very sensitive to not taxing, and it would be considered a tax if you had to be on there.
I have a question about 522s, since we're pretty getting into the weeds on that topic. Since we have multiple school districts in Enid itself, when you do a large area that includes more than one school district, is it all one vote and it passes or it doesn't, or does each school district
I'm not going
by the result of that
to get out
election?
over my skis.
Okay.
Okay, I
just wonder if that'll leave gaps in coverage and you're covering them but not them, and I just didn't know how complicated that was.
I think it's very complicated, but not undoable, for sure.
And then without getting in a lot of detail, and this might be for the chief, explain, I know multiple times in different meetings I've been in, the 911 issues that we have. So explain to me, when that call comes in to 911 and says, we've got a guy down on the ground, we need an ambulance. Can you walk me through that, what happens next? Or
You want it, or you want me to?
One of you?
So I'll try to talk. I don't know if I'll get it out, but basically, this is what Steve talked about earlier. When a 911 call comes into us, we have certain questions we have to ask. If it's a medical, we're going to transfer it to fire and life, and we have our questions for fire, but life has to ask those same questions. I think that's what Mr. Athey was talking about with redundancy. And that delays the call. I know you're aware that we're trying to come up with a unified dispatch. Of course, just like everything else, that's money. Mm-hmm. And so we're looking at maybe next fiscal year to look at that. So we're trying to improve the communications. There are gaps. We know there's gaps. We think they can be fixed. Jason and I have talked quite extensively, narrowing those gaps. And I think it would be good for the city and the county, but again, it takes money and it's going to take time, just like this committee's going to take.
If I might add to that, there is a certain amount of delay because they have to ask a couple of questions to know what kind of call it is and where it's at. And when it's transferred then to life, they start the EMD questioning to be able to give pre-arrival instructions, but they've sent the ambulance. They're not waiting to send that ambulance. So the delay is minimal, but it's still clumsy because they have to phone transfer as opposed to one button push. A lot of systems, it goes from CAD to CAD and nothing's missed. It just shoots over there and off they go. And so there's some human error, not error, but there's some human delay based on having to make the call, sending it over, making sure they picked up, those sort of issues.
There are times, it depends on the dispatcher and the situation. There's a lot of variables. But in general, when 911 picks up the phone and it's a medical call, sometimes they do spend a significant amount of time gathering information on that call. And then they forward the call to the life dispatcher. Now, after they transfer the call to the life dispatcher, they can push a button for a fire truck to go while they're listening to the life dispatcher talk to the patient, the RP on the phone. So there can be a couple minute or more delay while the 911 dispatcher is gathering their information before they hand off to life, and then they go through their process. Now, life dispatchers are trained, and Mr. Athey mentioned it earlier, emergency medical dispatching. It's EMD. It is like a certification. It's training that coincides with software that they use to dispatch calls. And there's criteria, and so they go through and they ask the question on the screen, and they click a yes or a no, and then they go next question, they click a button. It's software that guides them through the call to determine priority and gives them the assistance to pass on to the caller, whether it be CPR or anything like that, Heimlich maneuver assistance instructions. So it's going to be interesting as we go forward, because part of the upgrades we're doing to the 911 as fast as we can is increased education in CEUs, but also EMD dispatching is now mandated for all dispatchers. So when the state actually gets all that rolled out and we can get access to it, 911 dispatchers will be EMD trained. Then the question will become, when the 911 dispatcher gathers that information, they've gone through the EMD software, is it going to be a simple transfer, a button they push, or a light comes on, something on the screen, priority 1 or priority 2, CPR in progress, and the life dispatcher just sends a truck?
There should not be two centers doing EMD.
Well, I totally agree. That's why I'm saying a handoff instead of life starting all over.
So that only one set of EMDs going on. So I agree with you completely.
Trying to work through that.
Yeah.
You do think that's fixable, though, or that we can shorten that time or make it? I know somewhere in
One of our
here it
goals.
talks about drop calls or something, so.
That's one of our goals, is to simplify it, speed it up, absolutely.
Okay.
Yeah.
Okay.
I think, too, on the drop calls, the city is taking care of that with the new network. There were some issues with that for a while, which would have been during Mr. Athey's study.
Oh, yeah.
So those have been rectified. So I don't foresee that being a future problem.
Okay. Okay. Other questions?
I have one.
Yes, sir.
Dealing with this issue, because Mr. Athey, I heard you mention response time, and there's a financial aspect to this. My question is, when you have uninsured individuals that can't, pay for the service, because we don't deny them, I mean, we go get them and pick them up, what type of effect does that have upon, you all continuing to be able to operate your business? Because it is a business.
Well, it does two things. First of all, when you run on somebody who maybe doesn't really need to go to the hospital or doesn't need an ambulance, regardless whether they can pay or not, you're tied up with time. Fire department's tied up for the period of time they're there. First response, take care of the patient till the ambulance gets them. They usually can clear once they've assisted. EMS now is tied up for maybe an hour and a half by the time it's all done. So if there's no return for that, that's just lost. but we still do it. We do it next time, we do it tomorrow, we do it the next day. So it's no different than if we were working on a patient that has insurance or paid, that we're using that same resource. The issue is to try to match the amount of resources you have to the amount of demand. It would be nice to be able to carve out everybody who didn't need an ambulance out of the ambulance system. But better consultants than I have tried to get that done. It's really impossible to do. In fact, the mental health patient and the unhoused patient, as I've learned in Portland, Oregon recently, that's what we call them now, is the unhoused, may be the biggest problems facing EMS today. Because they have to respond, they have to provide those resources, and those folks need lots of care, but they don't need ambulance care.
Thank you.
Explain to me what a fly car is.
Fly car is a concept that has basically it's been around for a while, but has really gained popularity since COVID limited the number of paramedics. And that is, you might take a system here, for example, you might take a system and put 3 BLS trucks on the streets where you have nobody, just EMTs in an ambulance, and then you would have 2 roving Suburbans with a paramedic on it, with a paramedic equipment. And they would follow that ambulance to calls and provide the ALS care if needed, get in with the ambulance if they had to, leave the ambulance if they need to, and provide the paramedic care. So you now have more flexible paramedics responding, maybe more ambulances, but the ambulances are at a BLS level.
Who's providing the paramedics in the fly car? Who?
The service, whoever your service is, yes.
Okay.
City of Pasadena, Texas has just approved their provider to go to that. They're struggling with getting paramedics down there. So they now have a couple of BLS trucks out of their 8 are operating in the city, and a supervisor in a fly car will respond to those calls with them. So they can stop the clock when they get there. The paramedics got to be there to stop the clock, and they're able to put an ambulance or 2 on the street, even without paramedics, because they've got a paramedic that's showing up on the call.
Okay. All right. Commissioners, this is your chance.
Oh, I'll be around. They'll be able to talk to me later if they want to, for sure.
You'll be on the committee.
That's what I meant by I'll be around. Well, thank you. Thank you very much, then. I appreciate all your time and attention.
And we appreciate what you did on this. It was very easy to read. I do appreciate that. Very, very helpful. So,
Yeah, Mayor, I want to thank the ambulance services for coming in for this, too. You guys will be on the committee as well, so we try to figure out a better way.
Thank you.
you have enough time?
Yes.
Okay. All right, that being said, 3.2, we'll review the budget calendar for fiscal year 2025, 2024. Aaron?
Yep, short, sweet, to the point. It's that time of year again for the budgets, and we just wanted to get dates put in front of you to make sure that there's no conflicts and that we'll have, the majority of you here to hear all that presentation. We're proposing that we have the electronic draft for the new year out to you on Monday, April the 28th. That gives you a whole week to review what's in that draft before we have our first meeting. In May, the first regular meeting is on Monday the 5th. That's charter provision when we swear in the new commissioners. It is on the first Monday in May. So just to note that that's a change, although it is a regularly scheduled meeting on that Monday. And then we have 2 special budget meetings proposed, one on Thursday the 8th from 5:30 to 7:30 and one on the 13th from 5:30 to 7:30. And then the one on the 8th, we would like to hold a budget hearing and put that notice out to the paper for people to come and weigh in on the hearing part of the budget. And then we're tentatively asking for approval on the 20th of May at the regularly scheduled meeting at 6:30. And if we can't get the numbers together and get something that you guys are ready to approve, we'd ask that we have a special meeting on the 22nd to bring that back and have approval. I've looked at all of the area graduations, and none of them are scheduled on those nights. We've looked at Pioneer, Enid, Wacomish, Chisholm, OBA. They're all on nights that are not scheduled for meetings. So if you guys can take a look, and if you have any feedback, and if there's any dates that we need to look at change, please just let Gerald or myself know, and we will adjust as needed.
Would you like us to bring our binders from the last one?
If you would like to, yes, you can just bring
Recycle
those up
those?
to Jody and we'll get them replaced with the new draft. Yep. All right, that's all I have.
All right, thank you, Aaron, we appreciate it. We'll get all on our calendars. I thought we just had unlimited funds to spend every year.
I wasn't going to ask that question because I know better, but a good question for you to ask.
Yeah. Okay, with that being said, 6:15, we're going to adjourn, and we'll start our regular meeting at 6:30. We are adjourned.